Morning, everybody, and welcome to our first virtual interactive adults TOF seminar. OA TOF is often seen as a condition that affects particularly young people and young children. It's often repaired at a young age, and a lot of people don't necessarily have any follow-up care or requirements. But we know, obviously, that's not the case, and obviously complications continue through your life, your whole lifetime. Certainly from my own experience, from my own daughter, she's now got re-referred and carrying on, and she's 21 and carrying on with experiences. So at TOFS, we're calling for the NHS to recognise OA TOF as a lifelong health issue and working hard to improve the care of adults, including the production of a new adult OA TOF management handbook, highlighting issues faced by adults and teens. And that's been it's been written by our very own Dr. Caroline Love herself, an adult TOF, a member of the adult TOF working group, who is part of the TOFS team, bringing our unique understanding to to those people born with OA TOF. So we're trying, to do as much as we can, trying to make sure, we can get this seen as a lifelong condition. We are delighted to introduce I am delighted to introduce our first speaker this morning, Professor Manon from the Erasmus University in Rotterdam, which is the centre for our expertise for TOFs in the Netherlands. She's an amazing speaker. We had her before speaking for us, so we are absolutely delighted to welcome her back. Professor Spaander has been instrumental in setting up the specialist follow-up clinic for adult TOF care in the Netherlands and making it recognised as lifelong care. So during the presentation, she'll be talking about transition and lifelong management, OA TOF, and I'm sure we're all, as I am, interested to hear what she's achieved, both by herself and her team. And obviously, we can probably take lessons from what she's done here in the UK, to help us drive forward. So, Professor Manon Spaander, over to you.
Thank you, Duncan, and thank you for this very nice introduction and also the invitation that I may speak to you today about transition. It is a really great pleasure to be here from Rotterdam. Let me see if I can share my screen. So this is actually Rotterdam and Erasmus MC, and I'm sitting now over in one of these rooms over here. And here below, there's actually the Sofia's Children's Hospital. So if you look for the transition, it's a very short distance and an easy transition to make physically. So I have no disclosures, although I should say that a part of my presentation, there's a bit of overlap maybe from my previous talk, but I still think it's good to address it. Before I start to tell you and share our experience with the adult patients outpatient clinic for esophageal atresia patients, I want to share with you two cases. And the first case is a 20-year-old male that was referred to our outpatient clinic by his pediatric surgeon. And a few years ago, we have set up a consortium of all healthcare providers that are involved with the care of esophageal atresia patients and created awareness about the long-term problems that may occur. And that's why in the last few years, we received a lot of referrals, and this is one of them. He's 20 years old. He was born with esophageal atresia, with Tracheo-Oesophageal fistula. He had severe gastroesophageal reflux in his first year, and that's why he had a nasal application in his first year, and also had received several dilation of the esophagus during childhood due to the stenosis of the anastomosis. But currently he's doing quite well. He has no complaints. He did not use any medication, and no smoking, no alcohol, or no family history with any problems. We started with esophageal screening by performing an upper endoscopy, and this is what we found. So what you see here is the so-called Barrett's esophagus. This is the normal color of the esophagus, and this is now replaced by the more salmon-like mucosa of the stomach. We took biopsies, and fortunately, it was a Barrett's esophagus without dysplasia. And now he's in follow-up. The second patient is a 51-year-old female, also referred to our outpatient clinic by a pediatric surgeon, also born with esophageal atresia with Tracheo-Oesophageal fistula, but also has a tracheomalacia. And therefore, during childhood, she was already 14 times admitted for pneumonia. And since she was 18 years of old, there was no further follow-up. In contrast to the other case, she had complaints, and actually she had already asked her GP for a referral to a pulmonologist because lately she had more shortness of breath. She had always problems with coughing and fever and a lot of sputum production, but in the last week she also had more problems with the shortness of breath. So she came to us. She did not use any medication, no smoking. Sometimes she used a glass of wine. And also in this case, we started with the esophageal screening by performing the upper endoscopy. And here what you see is again the normal color of the esophagus, and this is the distal esophagus. And what you see over here, these are small lines, small red lines. These are small erosions, inflammations due to reflux. So she had a reflux esophagitis grade A and was treated with PPI. We also performed a CT scan for pulmonary screening. So in the last few years, besides esophageal screening, we have also started pulmonary screening for esophageal atresia patients. And this is what we found with these patients. And you see, these are the lungs. They're normally black. And what you see is here all these white rings and scars in both her lungs, but mostly here in the right lung, which is called bronchitis and is actually the cause of the fact that she now feels more shortness of breath. So later on, I will tell you more about this lung disorder and how this develops. So why is transition necessary from childhood to adulthood? And is this indeed a lifelong management? And I want to share with you this quote. It is actually a quote from one of my oldest patients. She is 67 years old, and she had a recall when she was around 64. And the first thing she said to me is that she was not aware that she was still a patient and had to see doctors. So what I will explain, we also explained to her, she already have had her esophageal screening, pulmonary screening, and also fortunately in this case, it was fine. So in the upcoming minutes, I want to share you why we have this adult care of esophageal outpatient clinic for esophageal atresia patients, when we're doing it and how we do it. And it is just to share you our experiences. And there is currently not a way that tells us based on evidence how we should do it, but I think we have shown that there is indeed evidence why we should do it. So a little bit of background. Fortunately, as you know, survival increased after birth and after surgery, but also more knowledge became available about the long-term effect. And we do know that in esophageal atresia patients, there's a higher instance of gastric reflux, up to 72%, and already during childhood. We also know that there's a higher instance of esophageal dysmotility and a higher instance of lung disorders. So let's start about the gastric reflux. So this is the normal anatomy with the esophagus going over into the stomach. And when at that point where the esophagus goes over to the stomach, there is the so-called esophageal sphincter. It's a muscle, and this muscle is usually closed. But when you eat and food need to pass through the esophagus to the stomach, then it relaxes and closes again. And the reason why it is closed is that it prevents the gastric acid to come up. However, during life, we are gaining weight, especially abdominal fat. And due to the abdominal fat, what happens is that this opening between the diaphragm gets wider. So a small part of the stomach now is coming up proximal to the diaphragm, leaving the sphincter over here and the diaphragm over here. So the diaphragm is actually helping the muscle to close more firmly, but now this part of the stomach is actually above the diaphragm, so the muscle cannot close that firmly, and reflux or gastric acid can come up to the esophagus and gives gastric reflux. The other fact is that also the muscle, the sphincter, is not closing well due to other factors. For example, smoking and cigarettes, there's nicotine, and in the muscle there are nicotine receptors, and when you smoke, the nicotine is coming up the nicotine receptor, and that provides a relaxation of the sphincter and therefore opening of the sphincter, and gastric acid can come up to the esophagus. So that's why smokers have more often problems with gastric reflux. So what about esophageal atresia? I think everybody may know this picture of the different types of esophageal atresia, with type C as the most common one, where the esophagus is disrupted, with also a fistula now from the distal part of the esophagus to the trachea. And what happens is, after surgery, or what the surgeon does is he's solving the problem by putting up the distal part of the esophagus to the proximal part. But by putting up the distal part, also the muscle, the esophageal sphincter, is now getting more proximal, creating actually a small hiatal hernia at a much younger age. Because normally in the general population, usually a hiatal hernia develops at the age of 25, 30 years. So is this higher incidence of gastric reflux, is this a problem on the long term? So in the general population, especially in Western countries, due to the way we eat and what we eat, and also to the fact that we have gained more weight, you see a lot of patients with reflux. A few of them have symptoms of reflux, and the typical symptom of reflux is heartburn. But still can patients have gastric reflux without feeling any complaint. So it is a really general problem, but not causing problems on the long term. Only a few people will develop the so-called esophagitis, so an inflammation of the esophagus due to gastric reflux, as I showed you in the second case. She has a reflux esophagitis. From the patients who have esophagitis and have inflammation of the esophagus, only a small part will actually develop a so-called Barrett's esophagus, as I showed you in the first case, where the normal mucosa was now replaced by gastric mucosa. And this is a process which really takes some time. So you have to have continuous gastric reflux before the normal esophagus mucosa will be replaced by gastric mucosa, as you can see over here. Barrett's esophagus is a so-called pre-malignant condition, meaning that during continuous reflux and inflammations, it can develop to esophageal cancer. And it's usually go by different steps. In the first case I showed to you, the 23-year-old male, he had a Barrett's esophagus without any form of dysplasia. But under continuous reflux and inflammation, in the Barrett's esophagus, changes can occur. Why in the Barrett's esophagus, low-grade dysplasia, finally to high-grade dysplasia, and then adenocarcinoma can develop. And adenocarcinoma is one of the type of esophageal cancer. So if we look in the literature, then besides the higher incidence of gastric reflux, it is indeed so that in esophageal atresia patients, there's a higher incidence of Barrett's esophagus and esophageal cancer, the adenocarcinoma, as also a younger age compared to the general population. So normally these conditions are found at the age of 60, 65. Besides the adenocarcinoma of the esophagus, also the literature showed that the other type of esophageal cancer, so-called esophageal squamosal cancer, was more often found in esophageal atresia patients compared to the general population, and also at a much younger age, around 40 years of age. If you look in what is causing this higher incidence, because squamosal cancer is usually seen in patients who smoke or use alcohol, or both. And there is another disorder, so-called achalasia, a disorder where we always also know that these patients are at risk of especially squamosal cancer, and that is achalasia. And achalasia is actually the opposite of hiatal hernia or gastric reflux, because in achalasia patients, this muscle, the lower esophageal sphincter, is not more relaxed, but actually more restricted, more closing more, as you can see over here. So there's like a spasm of the esophageal sphincter, causing that food cannot pass to the stomach. So as you can see here, it is really closed firmly, and this is just fluid contrast. What is just really small piece can pass, but most of the fluids and foods will stay in the esophagus, resulting in food that did not passage or vomiting. We think that the reasons why in these patients there's a higher incidence of squamosal cancer, and mainly also because the squamosal cancer are found in the distal esophagus, is due to the stasis of food and beverage, what cannot pass. And this problem with stasis of food and beverage is also seen in esophageal atresia patients. So we think that that is the reasons why also in esophageal atresia patients there's a high incidence of squamosal cancer. And this is mainly not due to the sphincter, as I showed you, but due to problems with the peristalsis of the esophagus. And if you look at the peristalsis of the esophagus, it's actually quite sophisticated system where the esophagus is doing two things. It's contractions and relaxation at the same time. So when the food passes, you see that at the same time, proximal of the food, the esophagus is giving contraction, while at the level of the food bolus, it is giving a relaxation. And by this contracting relaxation, the food can pass to the stomach. However, there was a disrupted esophagus. And although the surgeon has solved the problem, there's still the wave of the peristalsis will still be disrupted, giving problems with passage of food. And sometimes you need to drink to have the food passes, or take care in how fast you eat so that the food will not get stuck in the esophagus. It's all due to the peristalsis. So the stasis of food and the gastric acid or gastric reflux giving the Barrett's esophagus, we think is the reason that there is a higher incidence of both esophageal cancers of the squamous cell and of adenocarcinoma at a much younger age than compared to the general population. So how to prevent these cancers, both cancers of the esophagus? How to do it is by actually detecting the cancer at an early stage, or even better, to detect the low and high grade dysplasia and treat it. So if esophageal cancer cannot develop. The problem is that in these stages, you will not have any symptoms. So patient with a Barrett's esophagus, like for example, the first case, he felt well, he did not have any complaints. but also in case there is low-grade dysplasia or high-grade dysplasias, and you have the reflux and inflammation and stations, you do not feel sometimes these symptoms. So if we want to prevent esophageal cancer and we want to detect the high-grade and low-grade dysplasias, we have to screen patients because they will not come to us with symptoms. And especially, we know with esophageal atresia patients, sometimes when food did not pass it, they did not see it as an alarm system. It is sometimes quite normal for them. So that is why we have started esophageal screening in our follow-up by performing upper endoscopies, as you can see over here, where we go in with the scope, with light and water camera and a channel. And in this channel, we can put on our biopsies, to take biopsies of the mucosa. And with these biopsies, we also look under the microscope to be sure that there is no dysplasia in the Barrett's esophagus or in the squamosal mucosa of the esophagus. The other thing what we are doing is that we dye the esophagus with iodine. And this is a technique especially for detecting the squamosal cancer at an early stage. And as you can see over here, this is white line. And if you look very careful, you can already see the lesions. But with dye, you see it more clearly, and often it is more extended than you expected. You can see it here. This is where the dye is less, it's more wider. And it helps us for not only detecting it, but also treating it by removing it endoscopically. Recently, we have published our data of around more than 300 esophageal patients in diseases of the esophagus, showing that we could increase the starting age. So when I setting up the outpatient clinic, we started at the age of 17. So patients come from the Sophia Hospital to our outpatient clinic, and we start doing upper endoscopies for esophageal screening at the age of 17. But when we evaluated all the cases, we saw that there was actually no clinical condition that actually certifies the fact that we started at such a young age. So based on the fact that the first Barrett's esophagus that we found was at the age around 21 years without dysplasia, we say it is safely to start screening 20 years. We also saw that we had an interval of 5 years, that this can be safely increased to 10 years in case there's no Barrett's esophagus. Because in case of Barrett's esophagus, then the intervals will be shortened. But based on the data, starting age 20 years, interval 10 years, up to the age of 40 years, because after the age of 40 years, there is an increased risk, and we do not have enough data yet to be sure that we can safely extend the interval. So that's why still at the age of 40, it is every 5 years. The other thing we saw is that we have some patients that were curatively treated for esophageal cancer. However, years after their curative treatment, they developed another esophageal cancer because the proximal esophagus was still in place, or in another patients, he still had his esophagus. So that's why in this article, we also recommend that if you receive curative treatment for esophageal cancer, also start with endoscopic treatment, and usually you can start after 5 years. Then we have esophageal atresia patient with a lung gap with some colon intramural. So then there was a question, should we screen them as well? Because they have, could say, a lower risk of esophageal cancer because of the colon intramural. Oh, sorry, he's going for it. Actually, we found a colorectal cancer in the colon intramural in a 38-year-old male without any family history. And recently, I actually have performed a polypectomy of a polyp in the colon intramural, which appeared to be high-grade dysplasia. So by removing it, we have prevented the female for developing colorectal cancer. So that's why we still think that also there is a reason to screen people with a colon insuppinate. It should be said, data are very small. And then, so this with regards to the esophagus. I also showed you that there is a higher instance of lung disorders. And if you look at the pulmonary complaints of children with esophageal trachea, then you see that almost 3/4 of the children have complaints of coughing, pulmonary infection, bronchial hyperreactivity, so asthma, wheezing, and shortness of breath. And if you look at the number of admissions, then you can see that most of the part is gastrointestinal, but also in almost 40%, there is a respiratory reason for the admission. And these are data in children up to the age of 10 years in green. And you see after 18 years, the admission rates decreases. So what is causing these lung problems? And there are several reasons. And for this presentation, I want to share with the most common one, the so-called tracheomalacia. Here you see the normal anatomy of the trachea, with the trachea, and then it's divided into the left and the right bronchus, making of cartilages. And in tracheomalacia, this trachea is much more softened. So normally it is a quite stiff tube, but due to malacia, it is softened. And what happens? Here you can see, this is the normal situation. When you inhale, the trachea is getting wider. It's a really nice wide tube. And while you exhale, then you can see that the posterior wall, the back wall of the trachea comes inwards a bit. In patients with tracheomalacia, in case of inhale, you see that the trachea is already less widened. And during exhale, when you exhale, you can see that it is only really small. So it's more difficult to get air easily in and out. So here in a normal patient or a patient without tracheomalacia, exhaling, you can see here's the trachea, and you can see here the posterior wall, the back wall of the trachea, coming a little bit inward. And here in a tracheomalacia patient. So you see there's a really big difference and causing when air passes the wheezing sound, or also the specifically a sound when a patient cough with tracheomalacia. What are the complaints of tracheomalacia? Shortness of breath, the wheezing, ineffective sputum clearance. It's more difficult to get the sputum out. Coughing, pneumonia, or bronchitis. And then is the question, knowing that this is most commonly seen during childhood, as I showed you, most are the admission rate are seen below the age of 10, and after 18 years, you see that the admission rate is less. So is this a problem on the long term? And I showed you the second case with the female who had developed bronchiectasis. And this is, and here you see the condition. So this is the normal bronchus, and this is what happens with bronchiectasis. And with bronchiectasis, there is a widening of the airways due to the destruction of the wall. So here you can see that the wall is destructive, and due to the destruction of the wall, the bronchus get wider, but also you see there is more excess of sputum, mucus. And this can be seen in only one part of the lungs, but also in multiple parts. And it is the result of infections in the past, multiple infections. It can due to bacterial infections, viral infections, but also asthma or aspirations. And this continuous infection is damaging the bronchi, causing the bronchiectasis. It can be seen in different stages. So here is the normal patient. Here is a patient with bronchiectasis, only one lobe of the lung. Here in already 3 lobes of the lung. And in this patient, this in 4 lobes of the lung with also cysts that happens. And you can imagine that there is less volume of the lungs, more difficulty in breathing and shortness of breath, but also more affected, more vulnerable for infections due to the fact there is the more excess of sputum and stasis of sputum, which is easily to get infected. So you get a so-called vicious circle by starting first the infection, causing inflammation. The inflammation is causing the remodeling of the airway, the widening of the airway with the mucus accumulation. But due to the mucus accumulation and the difficulty for sputum clearance, you get colonization of different bacterial, getting infection. Infection is causing inflammations, and so the bronchiectasis is starting with only one lobe affected, and doing nothing, it can become to a severe disease with different bronchiectasis in both lungs. So how to prevent it? How can we prevent it? Because in case you have bronchiectasis, we cannot solve it. So it is like a scar. It will be there. So the only thing what we can do is to knowing that it is there and that we have to see what is causing it or optimizing the condition by reducing the number of infections. Because if we reduce the number of infections, then we will reduce the inflammations and the permanent, the airway remodeling, and actually stopping this vicious circle. So how do we do lung screening? We draw blood, perform a pulmonary function test, and a CT scan. These are the 3 investigations that every adult will get at every appointment at the pulmonary department. The reason why we draw blood is to be sure that there's not any allergies to food or to animals, because also an allergic reaction can give inflammation, and inflammation, I showed you, will start the circle. We perform pulmonary functionary tests to see the amount of air in the lungs, to see how forcefully one can empty the air from the lungs, so if there's a restrictive lung disorder or if there is asthma, also to see if there's a reason to start, for example, inhalation therapy. And we perform the CT scan to see if there is any infection. How do we prevent it? We start with few patients who have difficulty in coughing with coughing techniques, nebulize with salt solution. So the female I showed to you the second case. She has started to nebulize with salt solution to get a better clearance of sputum. She also received maintenance antibiotics to reduce the infection of the lungs. And important, of course, is prevent aspirations. As I showed you, due to the ineffective peristalsis of the esophagus, there's more stasis of the esophagus and therefore you're more prone for aspiration. So do not lie flat after a meal, but I think most of you will notice. Another important thing is do not wait in case of complaints of the lungs. So if you have coughing, have more shortness of breath, they need to call us because we don't want to get the infection more severe and the inflammation. We try to treat it as soon as possible to stop the inflammation reaction. So that's why currently we started with the follow-up of only the gastroenterologist. But based on the fact that we saw these disorders, my colleague of the pulmonology, Lieke Kamphuis, is also joining in with her colleagues. And also my nurse practitioner, Sophia van Balen, she is responsible for the continuity of care. Because also sometimes people have questions between their appointments or have worries about things. And she is the one that they can call almost every day and see how we can address things. So to summarize, when we see patients, so still patients are referred from our the childhood follow-up outpatient clinic of Sophia's hospital to the Department of Pulmonology for the lung screening. So it started with esophageal screening, but now we are starting at the age of 20. So they will see every patient at the age of 17 years. And then the second appointment will be made 3 years later, so at the age of 20. And during the second appointment, then also we from the gastroenterology department will come in for the esophageal screening based on the new recommendations. So 17 years of age it starts, and then every 3 years, and at 20 years, then the patient will see both of us. So to summarize, we have started this transition and lifelong management due to, we think, two important things. And the first thing is the esophagus, the problems with the esophagus due to the peristalsis and the reflux, providing patients a higher risk of esophageal cancer. And the only way to prevent it is by screening. And this we do by performing esophageal upper endoscopies, detect dysplasia, and in case of dysplasia, treat it. We start at the age of 20, every 10 years, and from the age 40 years, it's still every 5 years. But we have to wait for the data if we maybe can extend it. But currently, we don't think it is safe to do so. The second thing is the lung disorders. And we are working to also publish these data, showing that also on the long term, due to the continuous higher risk of infections, bronchitis is one of the long-term effects that can occur in esophageal atresia patients and appear to be also a higher incidence in these patients. So that's why we think that already at the age of 17, we have to see how the lung functions are, if people need, for example, inhalers to treat asthma, and decrease the number of infections so that we can reduce the damage of the lungs due to the recurrent infections. And that's why we start still at the age of 17. Thank you for your attention, and if there are any questions, I'm looking forward to address them.
Professor Spaander, thank you very much for that. That was brilliant.